This evening, I'm going to talk about tinnitus and bring everyone up to speed on where we are. So, almost 12 years ago, when Dr. Jackler came here, audiology did not exist. It was basically zero. And
it actually was zero.
And it went negative after I came.
No, Sharon Ritterman.
Yeah, oh yes, that's right. So we really started out with nothing, and from 2004 to 2014, when I stepped down, we made major advances in many areas. We got basic audiology to include a lot of things more than standard up to speed. We started with 3 cochlear implant manufacturers and got cochlear implant program up and running. We started intraoperative monitoring largely for cochlear implant related work, and we now are doing that remotely. So when the surgeon is ready for the monitoring, the audiologist can log in. We started with a hearing aid program. We have at least 13 manufacturers now, and we're doing about 60 per month of hearing aids. We started an electronic medical record system, and since then, we have about 34,000 case visits for audiology, all digital data. And we've been publishing from that. I've got a couple of publications that require computational analysis of the audiologic data, which is easy because it's all digital. We did do advanced audiology, including ADR and otoacoustic emissions. We really stepped up the vestibular part, especially when we moved to the new Stanford Ear Institute, where we added some other kinds of functions. I never really started a tinnitus clinic, mostly because I knew I was stepping down and didn't want the new person to have to deal with something that I could have. But I really started doing that and never got fully functional. And that's where we are right now with a tinnitus clinic. So today I'm going to bring everyone up to date on tinnitus demographics. I'm going to review, summarize, and evaluate current tinnitus practices. I'm going to describe our current understanding of primary tinnitus etiology. And then I'm going to go over some new directions for actual intervention for primary tinnitus. So tinnitus is by definition is the perception of sound without an external source, with or without a hearing loss. It's persistent if it's greater than 6 months, and it can be mild. Anyone upset about that? Yeah. That's basically what it is. It can be mild, moderate, severe, or bothersome, which we determine with questionnaires. A really important factor is this entity is multifactorial. It's got many different causes. And a very important function in otolaryngology is to do the comprehensive diagnostic work to separate out the tinnitus that is the result of a known problem, where generally if there's some intervention that can occur, the tinnitus can be resolved, separate from that's sometimes called objective or secondary tinnitus. And that's as opposed to subjective or primary tinnitus, which is largely idiopathic. So the kinds of objective tinnitus, Meniere's, vascular tumors, vestibular schwannomas, are not what I'm going to be talking about today. But I am going to be talking about subjective or primary tinnitus, which generally is believed to be associated with the central nervous system. So we have to also be careful with the demographics of this, because if you go and ask a group of people, do you ever have ringing in your ears? You're going to get a lot of that, because everybody has some ringing in their ears for some portion of their life. So I'm going to give the common percentages to show you that it's a very prevalent condition and also underserved. 15% of the population has reported primary tinnitus, and that's about 50 million people in the U.S. right now. And this is the most comprehensive demographic study. Kurhan is one of the authors in there, and we've had a project with him for several years. He's at Harvard and is looking at the effects of non-steroidal anti-inflammatory drugs on hearing, and tinnitus is a part of that. 2% of the population, or about just under 7 million, is severely affected. And there are known documented suicide reports related to this, not just the isolated case. Common reported costs, this is the latest number, the one up to about 3 weeks ago or so, was $1 billion annually. It's really now $2.75 billion annually. There currently are 1.5 million veterans receiving benefits, it's a little difficult to interpret this number because they don't separate the dollar amount for the diagnostic part, for instance, versus any intervention that goes on. I have a feeling that kind of number is associated both with the diagnostic and the intervention costs. So if we, for this talk today, I'm going to really concentrate on the primary tinnitus issue, not the other kinds of tinnitus. So the best study is now over a decade old, but it hasn't been repeated since. It has a very large N and very careful demographics related to the usual demographic kinds of instances. These are the cases that are primary tinnitus, not tinnitus in general. And there are a couple of things I'd like to point out. This is the age decade and the percent of the population coming in, the sample coming into that clinic. And there is a children's prevalence. It's not very much, but there is a small percentage. It grows during the decades from the 20s to the 40s, and that's probably because the unknown events that cause it occur during this age range, like sudden sensory neural hearing loss, for instance. And then it drops off, and then it starts to increase with age again. And because of this, and because of the bulge in the population related to aging, there's an expectation that the incidence of tinnitus in the elderly is also going to be increasing because the incidence of the elderly is increasing. Many studies show that there's really no sex difference in the percentages, and this group in particular, this is not taken hold, but they're proposing a word called Presby tinnitus to describe the tinnitus associated with the aging process, but no one's ever used it after that. This is the duration since onset of the tinnitus that they show up in the clinic. Most of them come within the first year of when they notice they have the tinnitus. And then it decreases in the years after that. But there is a percentage, it's more than 5%, more than 25%, who have these symptoms that exceed 5 years, and they keep on coming back looking for a solution. In this region here, I'm not sure if that decreases because the tinnitus is actually decreasing, or they've adapted to it, or that they had adequate intervention. My feeling is that they just quit coming in because nobody was able to do anything. So 25% are long-term, and again, we don't know if that long-term is because they have not adapted or that there's inadequate intervention. So you can find out about this tinnitus by presenting tones and asking the patient to match their percept with the characteristics of the tones that you present to them. So a common measure that's done is loudness matching. So you pick a tone and you keep on presenting the tone up and down in loudness until the patient says, no, that's louder than my tinnitus, no, that's softer than my tinnitus, until you get a value where it matches. And there's some, these data are repeated many, many times. This is the level of the loudness match above the person's hearing threshold in decibels. And you can see that the vast majority of them match a tone at very low levels. This is very near threshold. So their percept matches in loudness to a very low level signal. There's only about 16% greater than 15 decibels. Another factor is, which is why this is not measured very often, is that if you record their severity, their reaction to this tinnitus, it's unrelated to these loudness levels. Some patients with very low loudness matches are very, very bothered by this. Others with high loudness matches are not bothered by it. The relationship between those is not, does not have a high correlation. But it's routinely at levels near threshold. You can also do pitch matching. You can take a tone and vary it in high frequency or low frequency until they do the same matching. And the striking thing here is that a very, very large percentage, 96%, match with a tone. It doesn't mean their tinnitus is tonal, but their tinnitus is frequency specific enough that they can match a tone to that, their percept. There is a percentage that are unable to pitch match. Another factor is that 31% match at frequencies greater than 8 kilohertz, which is the upper frequency for a standard audiogram. So a very large percentage match tinnitus tones to frequencies that are higher in frequency than the standard audiogram. And then some just can't match. So the factor here is that wherever we find the source of this tinnitus, we likely will be able to rely on the tonotopic organization of the auditory system. It's likely that the problem is going to be associated with where they're pitch matching, and because the auditory system is tonotopically oriented, we can use that to our advantage. There's another factor called residual inhibition. It's sometimes called the shower effect. The patient has tinnitus, they take a shower and they listen to the noise from the shower, they come out of the shower, and their tinnitus is reduced. And it's reduced for a minute, or several minutes, or 20 minutes, and that's called residual inhibition. We used to measure that regularly as an indicator of whether sound therapy would be beneficial to reducing tinnitus, but it's not standardized. And it also is unrelated to loudness, and it's very difficult to quantify. There are two groups here where we have a loudness match, and then presenting a 60-second tone and asking them to do the loudness match again to check for this residual inhibition. 25%, and their tones are less than 10 dB that they match to, have no residual inhibition. 33% or so do have total inhibition. And then you can do the same thing for the group of tinnitus patients who have loud matches, and the numbers differ. So basically, we don't use this very much, and it's not very predictive of anything we can do intervention. So the demographics are, it's a chronic condition, there's large prevalence, increasing incidence largely because of aging. It's a very high cost to society. NIH now has an emphasis to look into this, as does the VA. So what is the current practice? Here's the current practice. Okay, Mrs. Jones, what is your problem today? Tinnitus. Okay, how bad? Oh, it's very, oh, wait a minute. Blood? Choking? Oh, I'm sorry, Mrs. Jones, I have to go. I'm going to let you talk to my chief resident, and that person will take you. Another current practice is, look, Mrs. Jones, it's not cancer, learn to live with it. Neither of those are very good. So in 2014, the American Academy of Otolaryngology got together 23 experts and put together a white paper on current tinnitus practices. They did it on evidence basis, and They ended up with recommendations that fall into these categories, either for or against, strong recommendations, recommendation, optional, or no recommendation. And they came up with this decision tree. I actually did this. I went to several colleagues and I said, did you read this article? And they said, yes. And I said, do you understand the decision tree? And they said, no. It's very, very complicated. So what I'd really like to do toward the end of this presentation is to give the main points of this so that everybody understands this decision tree without getting lost in the details. So they broke down the recommendations in diagnosis and several interventions. So for diagnoses, they recommended targeted history, audiology, and the audiology is two categories. It's right away if the tinnitus is unilateral or less than 6 months, or the person reports a hearing difficulty. It's routine audiology is optional if it does. Why would anyone select audiology as being optional? I never understood that. So it's an optional recommendation. They definitely recommended against, strong recommendation against imaging for tinnitus. It doesn't mean you shouldn't do imaging for other things, but for tinnitus specifically, strong recommendation against. A strong recommendation to determine the magnitude. And my comment here is that we now have several tinnitus questionnaires that have been validated, repeatable, highly reliable, a lot of literature reported on them. We're talking about 10 minutes, 5 minutes of time to do these. They can be repeated, and I think a group coming together and deciding on which of these tinnitus questionnaires to come up with a standardized definition of what's bothersome and not bothersome, and then if it's persistent. They also recommended counseling and education. Everybody does this. They give all kinds of brochures. The thing I want to point out is that the counseling should include proven interventions and non-proven interventions. That's what a lot of these patients want to know. And of course, support organizations. The diagnostic counseling is very important because an initial case coming in are very concerned about some serious disease, and giving them assurance otherwise is a so they also recommended hearing aids. A large percentage of the tinnitus patients do have hearing loss, and many, they have mild hearing loss, and many don't wear hearing aids. Hearing aids has an advantage, first of all, helping you understand speech better, but also to ameliorate some of the tinnitus symptoms. So this is a study, again, large N, recently, where the subjects were given a hearing aid and asked about their satisfaction of the hearing aid in relation to the wearing the satisfaction related to the tinnitus condition in relation to wearing the hearing aid. 96% preferred wearing the hearing aid as a measure of tamping down the tinnitus. There's a really important aspect of this. This is the satisfaction score as a function of how long they're wearing the hearing aid. And some of the hearing aids had maskers which cover up the tinnitus. So you can see when you put a hearing aid on in the first month, they get some relief, they're satisfied with their tinnitus with the masker, but that decreases over time. But the benefit that the hearing aid provides increases up to about 6 months and then stays the same. So the committee recommended highly for hearing aid evaluation. Sound therapy, this is more related to the psychological reaction to the percept. We talked about masking. There are other sound kinds of therapies which deal largely with habituation to the phenomenon, and some use music signals. Many use environmental sounds, that is, buying one of these sound machines at Bed Bath & Beyond and listening to waterfalls music. The committee concluded that sound therapy provides benefit, but there's no evidence of one sound therapy showing benefit over the other, and they suggest that it be combined with counseling. They also found lots of evidence that cognitive behavioral therapy does provide benefit as well. And the essence of that is to teach the patient how to identify and restructure their maladaptive reaction to the tinnitus. It's proven effective for depression, anxiety, other kinds of conditions, and tinnitus. It's typically an 8-week program. And one thing we did was to make contact with our colleagues in psychology and psychiatry. Today we have Dr. Bruce Arnault here, who's an expert in delivering cognitive behavioral therapy. And one of the factors that I think is very, very good is that he and his colleague, Chris Hayward, are now discussing doing cognitive behavioral therapy for tinnitus at the otolaryngology clinic. There is a stigma associated with a referral to a psych department, so this would solve that. The group sessions are acceptable as well. There's wide variability across the world related to the experience of the provider. But they recommended, the committee definitely recommended against all pharmaceuticals, no antidepressants, anticonvulsants, anxiolytics, or intratympanic injections. Now, this does not apply to comorbid conditions.
Yeah, I was going to say, because a fair number of folks who suffer from tinnitus, as opposed to merely having tinnitus, are depressed. And the underlying depression treatment often helps their overall sense of well-being.
So that does not apply to comorbid conditions. And one factor is that sometimes the hearing aid helps, but the patient takes the hearing aid off, tries to sleep at night, and the tinnitus prevents or interferes with their sleep. So is a sleep disorder a comorbidity? That was not addressed in the. They also recommended against any of the dietary supplements. All of these. I don't know how the lipoflavonoids get advertised, but they're advertised all over specifically for tinnitus. There's no evidence that there's any effect. So this is a question I'd like to pose. Many of these interventions do have a placebo effect. Is anyone in favor of recommending a placebo as an intervention? Do that? You know it's a placebo, do you recommend it? Come on, don't be bashful.
Try it.
So try it, it can't hurt, right? So I don't know what the answer is there, but I do know colleagues who, they know it's a placebo, they know they're going to capitalize on the placebo. Acupuncture, they didn't make a recommendation at all, mostly because the committee couldn't come up with, they were split, the committee was split, between no recommendation and against recommendation. And I just wanted to point out that some patient populations use acupuncture for a variety of things, and I think that may be interacting with the recommendation of the committee. They also did not recommend transcranial magnetic stimulation because there's no evidence that it works, but there's a lot of literature out related to that. So here is the summary of the AAO guidelines. Diagnosis should include history, magnitude, and an audiology referral and no imaging. Intervention should include counseling, hearing aids, cognitive behavioral therapy, and no pharmaceuticals. So there are many theories, and this really gets mixed up in the literature because some of the investigations are mixing up transient tinnitus, like that associated with high doses of aspirin, with chronic primary tinnitus. They may or may not be the same. There's also the question about hearing loss. There's also the question about association with a condition called hyperacusis. And there are many mechanisms associated. Common ones are noise exposure and some of the NSAIDs. And a very common consensus now is that the origination is related to hair cell deafferentiation. So let's talk about that. If we look at the organization of the auditory cortex, from the cochlea up to the cortex, we can see the tonotopic organization at the cortex. This follows the audiogram. And if we now put an electrode on the auditory cortex, in a normal case, this is found out throughout the central nervous system, the firing of the signals is not synchronous. In the abnormal case, where you do the same thing, but this time you have no hair cells, some missing hair cells, the afferent input is not connected, and now we're finding at some labs that things like noise exposure and some ototoxicity not only interferes or eliminates the hair cells, but there can be effects at the first synapse as well that are long-term. That can lead to dedifferentiation effect as well. So the abnormal condition is synchronous. And the idea here is to, under this theory, is that the synchronous firing is what percept is about. And if you can disrupt that perception, you might be able to disrupt the tinnitus. So we can see biological markers of this through a wide variety of kinds of physiological measures. A common one is the ongoing spontaneous neural activity that you see in EEG or with MEG as well. And this is broken up into the usual EEG bands of delta, theta, alpha, and gamma. And those are beginning to be associated with the abnormal synchrony that you can observe. There are also other ways to do imaging, which are consistent with this, that generally are measures of overall metabolic activity, largely blood flow, as a proxy for what the neural functioning is. And you can see it under PET scans, under functional magnetic resonance imaging, and under near-infrared spectroscopy. So all of these are viable. My personal preference is to stay with the EEG, largely because this is a direct measure of neural activity in the brain. This is indirect. You're making measurements of blood flow and associating that with the abnormal activity. So for tinnitus etiology, consensus is that it's really not the hair cells, it's dedifferentiation that is the fundamental problem. It is observable at various neural levels throughout. It does follow the tonotopic organization, and the primary effect is at the auditory cortex. So, and then the etiology is related to dedifferentiation and results in abnormal synchrony. So now we're moving on to a totally new tinnitus intervention. So the traditional neurotransmission is concentrated on understanding the effects of one cell causing another cell to fire. That's neurotransmission. It's neuron to neuron. It causes spiking, so if this cell fires, it causes the next cell to fire. And there are neurotransmitters involved, and Tony Ritchie is very involved with neurotransmitters at the synaptic level in our department here. And there are common neurotransmitters which are now well understood. If we move to the concept of neuromodulation, that has to do with groups of cells, and the effect is related to the synaptic bed. And the idea is that neuromodulation refers to factors that modulate a group of firing cells. And the neuromodulators are extracellular. And the most important thing here is that many believe this is the source of neuroplasticity principles. So if you use neuromodulation to change the neuromodulators, there's a possibility that neuroplasticity can be informed to cause a more long-term effect to reduce the abnormal synchrony. So 2 years ago, my friend and colleague Peter Cass, who's right here, is at Jülich Research Center, which is in Germany. It's essentially equivalent to the National Science Foundation here. So it's a state-supported research institution where a lot of basic science goes on. And he's been a pioneer in neuromodulation understanding for a variety of chronic neurologic conditions. Tinnitus is one of them. He has an MD from Ulm and a PhD in mathematics and physics from where? Stuttgart, and also a postdoc in neurology. And he has a colleague that works primarily with Christian Huffman in Jülich. And he set up a formal collaboration between the Jülich Institution and Stanford centered on neuromodulation. But he's working in many areas that have chronic neurological effects that are associated with abnormal synchrony. In particular, Parkinson's disease, epilepsy, stroke, migraine, and other conditions. So he's only part-time yet, but will be here full-time in the Department of Neurosurgery. And when he came here in 2014, we've worked out an arrangement where the tinnitus neuromodulation research would go on in a lab in otolaryngology. So he has about 200 patents from Jülich, and he's already been working here, and we're now adding patents to the Stanford portfolio in the area of neuromodulation. And he has an interest of starting new courses in computational neuroscience, which is a lot of this is based on. And so we'll be having postdocs and graduate students in neuroscience related to that. Gabriella Musakia is a very experienced neuroscientist, and she works with me in the otolaryngology department on this research project. So a lot of the physiological-based measures of understanding tinnitus use animal models, and there are a lot of papers coming out related to animal models. And I just want to go through my personal opinion on where we stand with animal models. The model assumes that tinnitus can be reliably induced, and I have a big problem with that because we know that noise exposure can induce tinnitus, but we also know that many people have noise exposure, hearing loss, and no tinnitus. And the relationship between a dose of noise and resulting in tinnitus is nowhere near 1-to-1. The same thing happens with other toxic, ototoxic agents. You can have gentamicin exposure and have hearing loss and no tinnitus, or you can have hearing loss and tinnitus. And I think it's a very big problem to come up with a scheme on an animal model that says this is going to cause tinnitus. Now, animal physiology is very, very well worked out for peripheral measures. When Stefan first came here, we set up the auditory core, and I did some of the original measures on peripheral sensitivity, otoacoustic emissions in the mouse model, and it's very, very reliable. The problem is that's not where the tinnitus is. So the associating the physiological models with the tinnitus in animals, I think, is the problem. The other problem related to animal models is that the toxic effects of the agents you're trying to cause tinnitus also cause changes in the auditory system, like changes in hearing sensitivity. It's very difficult to separate those two. So what is commonly done is a behavioral measure, which sounds good on paper, but I think it's got some limitations. Basically, it works like this. You give a toxic agent, assume that there's tinnitus there, and now you try to measure from the animal if there is tinnitus. And the way that's done is you present noise similar to what you expect the tinnitus to be. So, shh. Then you stop the noise, the animal's listening, and if the animal doesn't hear anything, and then the noise starts again, the animal has a reflexive reaction. And they're defining tinnitus as tinnitus being present that is not distinguishable from the noise. So the noise goes on, shh, noise stops, the tinnitus is there, the animal can't tell the difference, and the noise starts again and doesn't jump. And that would work if the tinnitus matched very, very, very closely to the noise, and there's no way to show that. The most damaging study was done just a few months ago, where they tried the system validated on humans, and it wasn't validated. So I think there's a use for using animal experiments for tinnitus studies, but I think we're nowhere near getting a generally accepted model. So if we now categorize neuromodulation therapy, we can present the signal several different ways. One is transcranial with magnetic stimulation, so you can do magnetic fields to induce an electrical signal in the brain and activate the cortex, which sounds like a good idea. You can see the fields, the magnetic fields here as they go into the head, and the problem is they're not very focused. So the existing transcranial neuromodulation interventions are activating large parts of the brain. In fact, there are several reported cases where this intervention actually caused a seizure in a patient who doesn't have the seizure disorder. John Ogilvie is not here today, but he tried this on his own head, and it jerked his arm up. So he has some concerns about transcranial. And we asked him about it. He said, no, it was totally out of control. It just shot his arm up. So you can also present electrical signals transcranial, and it's got the same problem in that it is not very focused. So you don't really know what you're stimulating. There's been some studies with deep brain stimulation, which is a natural fit here because Peter is doing these kinds of experiments with Parkinson's disease. And Steve Chung, a fellow of Rob's, did the first study on this at UCSF. So the idea is they have deep brain stimulation for Parkinson's where the electrodes are in the middle of the brain, and they're presenting signals to disrupt or interfere with the activity in that region of the auditory system. You can also activate the cortex by acoustic means. So these are more direct, and we're focused on using acoustic stimulation for the intervention. I'd like to next talk about what we understand from other kinds of implants as a guide for what we can do for neuromodulation intervention experimentally and clinically. So for cochlear implants, the electrode goes right in the cochlea and activates the entire remaining neural system, which is normal. In some cases, where the eighth nerve is not viable anymore, is a brainstem implant where the electrode goes right on the brainstem, missing out on all of the pre-processing at this region here. And the brainstem implants don't perform nearly as well as the cochlear implants. If we look at vision, there's a large project here in ophthalmology related to developing a retinal implant. And it's showing good promise, largely again because the electrical activation is activating normal nerves at the periphery. There has been groups in the past where they tried to activate the cortex for visual activation, and it doesn't work well, mostly because it's not capturing the normal neural structures up to there. So if you do acoustic, you can go through the auditory system. It's direct and non-invasive. If we were going to do cortical on the auditory system, a good place to do it would be to put the electrodes on the cortex. In fact, you could put the electrodes extradurally, so you wouldn't even have to enter the brain area. So Peter did the original proof of concept neuromodulation tinnitus study, 63 subjects, and based a lot on mathematical modeling, understanding the neuromodulation concepts. And it goes something like this. If you take a patient like this audiogram and present pitch matching, you find out that in this patient, the pitch matches at 3,000 hertz, and it's about 10 decibels above the patient's threshold. and can be repeatable. If you now take 4 tones, Peter did a lot of the work prior to this, spaced strategically around that tinnitus area, specifically targeting the cortical region where this synchrony is occurring, and present it as a therapeutic neuromodulation signal that can disrupt the synchrony. Here's what the tones sound like. So they're going around the tinnitus pitch in a very specific way based on a lot of modeling work that has been done. If you then take a placebo set of signals, so you do the same thing at a very low frequency that is not associated with tinnitus, you now have a placebo condition, and you present it several hours a day for 12 weeks, and you measure the tinnitus again. In this case, there are a lot of other data, but in this case I'm only going to show something called a visual analog scale. You present a scale to the patient, unmarked, and you say, how loud is your tinnitus? And the patient puts a mark on it. And then if the tinnitus drops, the patient puts a mark at a different spot. So this is the visual analog scale benefit at the end of therapy for the placebo and for the therapy signals. Benefit means it was 80 on the scale before starting and 40 afterward, and you subtract the two, it's a 40 benefit. And the benefit went up, but the very most interesting thing to me is that there was a long-term effect. 4 weeks after the therapy intervened, the therapy was still markedly above the placebo. If you do the same thing for loudness, not loudness, but tinnitus annoyance, you get the same kind of result. Compared to the placebo, there's a big effect, and that effect lasts after you do the stimulant. Okay, lastly, I'd like to show you what we're doing on the research side related to this. So we decided to do EEG, and we're doing sound localization, so we have 256 electrodes around the head. And we've already identified 56 tinnitus patients at the Stanford Ear Institute who are willing to come in for research. That means no benefit to them, they're just going to come and sit for our experiments. It's very complicated analysis. We have local computing, and we also have cluster computing. Some of the analyses for modeling might take 8, 10, 15 hours of computer time. And we now put it on a cluster, which is basically many computers operating at once. And you can knock that down to 40 minutes. And we have that all set up. So after the electrodes are on, there's a geodesic dome that goes over the head that has 11 cameras, and GPS signals are used to identify where the electrodes are. We have similar labs in neurosurgery, largely for Parkinson's and migraine, that Peter is working on. We also recently made connection with the Vision Lab on the main campus, who has a similar system, and they're interested in neuromodulation techniques related to the vision system. After the electrodes are on, you can identify where the electrodes are based on the GPS. We can also co-register an MRI image. So we now have the MRI image of the subject we're using, and we now believe we can get to 2 millimeter resolution on the cortex. We can do all of the standard EEG measures. We have worked out the source localization, that is finding out where on this brain. Remember, it's an MRI image of the subject. And basically, we can use event-related potentials and a heat map. So the heat map shows where the activity is on the image. Yellow is the hottest. And then we use dipole technology, which is a vector quantity, which says where the maximum electrical activity is on that image, right and left lobe. And this line down gives you an indication of how it is in relation to the surface of the cortex, because in this region we have sulci. So we also did some experiments with simulated tinnitus. So we took a normal hearing person without tinnitus, measured their dipole on the image, which is here, and then presented a 1,000 hertz tinnitus tone, simulated tinnitus tone, and it shifted that. So we think we can measure simulated tinnitus with this mechanism. We also can do regular EEG measures. So this is the power in the delta band with tinnitus and with the simulated tinnitus and without tinnitus. And we can do these experiments now as well. One of the things that's difficult that we need to test to make sure of is the repeatability of the tinnitus match. And so at ULIC, they developed an automated tinnitus matching procedure, and we just published this paper. So this is the difference between the tinnitus tone that you put in and the tinnitus match. And you can see there's an average, but the data are all over the place. If you use the automated procedure, many more of the, statistically significant, many more of the matches are within a much smaller range. So we believe we can now do quantitative, reliable tinnitus matches. So we're also beginning to use iPods and iPhones because some of the tinnitus intervention is multiple hours a day, multiple days a week. This is a study that Nick and I published with Marcus Huth related to measuring noise exposure to cinemas. And this just shows that your average iPhone, this is 6 examples, has a frequency response that's extremely flat all the way out to the high frequency region. Sound level meters have this variability. If we put a known sound pressure level signal in and measure what the iPhone says it is, put 60 in, you get 60, put 90 in, you get 90. It's very linear. The 6 phones fell on top of each other. They're so regular. So it's as good of equipment as the audiometers in the clinic. At ULIC, they've already done several studies in Europe repeating some of these results in up to about 500 patients already. So, in summary, for tinnitus, diagnosis is very important, and the medical diagnosis of primary tinnitus is really essential. There are some standard interventions that are effective and should be tried, hearing aids and counseling especially, and to this can be added cognitive behavioral therapy. The etiology is now better understood. It's primarily a chronic brain condition, not a cochlear condition. And the neuromodulation interventions we're talking about are extremely promising because instead of covering up the tinnitus or instead of working on changing the maladaptive psychological behavior to the tinnitus, we're talking about actually reducing or eliminating the tinnitus long term. Thank you very much.
Wow.